Thank you for joining us today. My name is Carissa Charles, and I serve as the Director of Programming at Heart Valve Voice US, and I'm moderating today's webinar. This webinar will be recorded and will be uploaded to our YouTube channel shortly afterwards. As you may know, today is National Heart Valve Disease Awareness Day, and it's an annual day dedicated to increasing recognition of the specific risks and symptoms of heart valve disease, improving detection and treatment, and ultimately saving lives. More than 11 million Americans have some form of heart valve disease, and more than 25,000 people will die from the disease every year. However, Black patients tend to experience more disparities in the treatment of heart valve disease. Statistically, Black individuals are more likely to have blood pressure, diabetes, and high cholesterol, which are all risk factors for developing valve disease. Despite the many advances in heart valve disease treatments, minorities are still significantly underdiagnosed and undertreated. Today, we'll talk about why these disparities exist and steps providers, patients, and organizations advocating for heart valve disease awareness can take to move the needle towards improved health equity. So let's get started in introducing our panel. Dr. Aaron Horne is a structural and peripheral cardiologist who treats people across the gambit of cardiac and vascular issues. His area of expertise include taking care of patients with chest pain, palpitations, shortness of breath, leg pain, and episodes of syncope, which is when a patient loses consciousness. He is also passionate about educating the community on the importance of health equity and how focusing on those most in need can help bend the cost care within cardiovascular disease. Dr. Rachel Bond is a board-certified attending cardiologist who has devoted her career to treatment of heart valve disease through early detection, education, and prevention. She is the author of several review papers referencing sex and gender differences and cardiovascular conditions that predominantly affect women, along with the opinion pieces aimed at addressing health equity, reducing health disparities, and promoting the professional development of women and minorities in health science profession. She has a passion for advocacy of education and mentorship and has advised as an expert source through news and media outlets. Her clinical interests include heart disease prevention, pregnancy-related conditions, cardio-oncology, and lipid disorders. Her research includes the heart-mind connection, cardiorheumatology, and gender disparities in valvular heart disease. And we also have our Vice Chair, Teresa Wright-Johnson, who may be joining the webinar a tad bit late, but I'll go ahead and give her bio anyway. Teresa Wright-Johnson is a congenital heart disease survivor and multiple sclerosis warrior. She is also a distinguished patient advocate and an inspirational speaker, author, and consultant. Diversity, inclusion, and health equity matter to Teresa, and her advocacy efforts solidify her commitment to amplifying the patient voice, specifically those who are underrepresented and underserved. Teresa is a columnist, contributor, and guest writer for multiple patient advocacy sites. She serves as the board of directors as vice chairman for Heart Valve Voice, board of directors for the Lehigh Valley American Heart Association, engagement committee member and co-chair of the Equity, Diversity, and Inclusion Subcommittee for Congress and Multiple Sclerosis Association of America, African American Advisory Board member, and she is also a member of Zeta Phi Beta Sorority Incorporated. So now that we've given an overview of our panelists, let's get started and jump into the conversation. So Dr. Horne, can you give us more information about how heart valve disease is defined and some of its risk factors?
Sure. So thank you again for having me today on this Heart Valve Disease Awareness Day. I'm really happy that we're starting to shine more of a light on this particular disease state. Taking a step back, I think that as a healthcare community, we've done a good job of educating people about the importance of disease states such as heart attacks and strokes. Right? When people have chest pain, the first thing that often comes to mind is whether or not they have blockages in one of the arteries that gives blood supply to the heart muscle. And also within the same sort of heart and vascular circulatory system, we've done a good job in terms of being cognizant of certain clinical symptoms associated with stroke, whether it be slurred speech, facial droop, strength asymmetry. We know about the FAAC acronym and the like. However, where I think we really need to make more progress is discussing valvular heart disease. So the heart has, and again, I'm thrilled to know that we have a very robust registration here. However, that also means that we have people from across the gambit, some people that are very familiar with heart disease and some that are not. So I'll speak in very plain English, and hopefully this will spur an additional conversation. And one of the things that Dr. Bond and I really want to make sure that we do is make this an interactive exchange. So if at any point in time people have any comments, questions, just put it in the Q&A or just raise your hand and we'll make sure that we pause, answer that question, and then proceed with our subsequent conversation. So the heart has a left and a right side, top and a bottom, separated into 4 chambers by valves. So over time, those valves that separate the different chambers of your heart either become stenotic or regurgitant. What does that mean? I think stenosis is a little bit intuitive. It means that it becomes sticky. It doesn't open that well over time. Regurgitant means that blood, instead of going from upstream to downstream, can go from downstream to upstream. Often used the analogy as if you have a suction vacuum on a push door. Early on, when that door is brand new, you push the door open and it suctions back closed. You push it open, it suction back closed. Over time, you push it open, it might swing back a little bit before it closes. That's the regurgitation of the blood going to that other top portion of the heart. Now, the reason why I said we haven't done a good job of talking about valvular heart disease is that, again, we have the aortic, mitral, tricuspid, and pulmonic valves. And all of those valves now are becoming much more prominent in the disease states that we see in our patients. All of them are incredibly important. I'm going to just focus on 2 in particular briefly, but this is just sort of just trying to serve as an introduction to the topic. So the aortic valve is the main valve that lets blood leave the main pumping chamber of your heart and go to your brain and all of your vital organs. Now, 26 to 29% of patients 65 years of age and older has aortic stenosis, which means that aortic valve doesn't open well. 1 out of every 8 adults 75 years of age and older has moderate to severe aortic stenosis. And we know that now, obviously, this data has been skewed with the pandemic and the like with COVID, and unfortunately, we lost a lot of patients, many of whom were older and disproportionately happened to be from underrepresented minorities. But nevertheless, the fastest growing population in the United States are people 85 years of age and older. And so I'm talking about this disease state being aortic valve disease that affects older patients. So when you have chest pain, shortness of breath, lightheadedness, dizziness, and you're older than 75 years of age, while you might be wondering whether or not you have blockages in the arteries that give blood supply to your heart muscle, I would encourage you to think about whether or not there's a problem with that aortic valve. And we know that in the real world, over a 10-year period of time of registry data, which we follow as practitioners, that only 4%, less than 4% to be precise, 3.8% of African Americans in the United States get access to this life-saving therapy. What do I mean life-saving therapy? We know that untreated symptomatic severe aortic stenosis has a 50% mortality at 2 years untreated, meaning if you have this disease state and it's not treated within 2 years, you have a 50% chance of dying. And only 3.8% of Black folks in the United States get access to this particular treatment modality. So we talked about what are the risk factors. So there's no question that, again, this is a disease in aging. But if you look at other risk factors that contribute to this, you're going to look at patients that do have certain risk factors that are going to increase one's likelihood of have calcium deposition build up in one's aortic bed, including your valvular system. You look at patients that are on dialysis, for instance, and who are the patients that are on dialysis? Patients that have high blood pressure, diabetes, overweight, obesity, metabolic syndrome that unfortunately happens to disproportionately affect people of color. That's inextricably linked to patients that are across certain socioeconomic strata that, again, disproportionately affect underrepresented minority patient populations. So those are some of the risk factors. The one thing that I'll say and pause, because obviously I want my colleague, Dr. Bond, to get in, who just has a plethora of knowledge and experience on this topic. The one thing that I think that I want everybody to take out of this particular discussion is that valvular heart disease is an issue. It is a problem. We have well validated and delineated the fact that this problem exists. What I also want you to take home from this is not a complicated issue that cannot be addressed. The problem is when we talk about disparities, oftentimes we get the pushback that this is a complicated issue that's so multifactorial that it's too complicated to address. That is not the fact. This has been very well studied. We know what the issues are, and we know how to address them. So once you embrace that this is something that needs to be addressed, the first thing that we need to do is engage. And once we engage, we're going to make a lot of progress on this topic. So I'm really excited to be here, continue to be an advocate on this topic. Obviously, present company with my esteemed colleagues. Carissa, thank you for hosting us. Pleasure to be here with Teresa Wright-Johnson and my colleague and friend, Dr. Rachel Bond, as well.
Thank you, Dr. Horne. And definitely with today being Heart Valve Disease Awareness Day, we really want to make sure that we're engaging our community and bringing a voice to this topic as well. And thank you, Teresa, for taking the time to hop in today. Before we pivot to you, Teresa, I'd like to take the time to speak to Dr. Bond and just have a brief overview on how heart valve disease is diagnosed and treated.
Yeah, I want to echo a lot of what Dr. Horne made a comment about, in the fact that I would say, have to do a slightly better job in understanding the importance of valvular disease with the aging population. You know, statistics demonstrate that it's going to probably overpass the leading cause of cardiovascular complications by the year 2050, as an example. So once we now that we understand what the valvular conditions are, and the reason Dr. Horne highlighted aortic stenosis and also dabbled in mitral regurgitation is because those are the two most common causes of valvular disease. It's really important to figure out how to diagnose it. The first step always includes the ability for us as clinicians to use our stethoscope and listen to your heart. If you've been told in your lifetime that you have a cardiac murmur being an extra heart sound, it's really important that you understand that those are not always benign, and oftentimes they do require additional testing. I will say that I've seen a multitude of patients that have gone years and years, sometimes decades, being told that they have a murmur, and no one ever took the next step to figure out why that murmur exists. Oftentimes, once we hear a murmur, which is that extra heart sound, we're going to want to do a test called an echocardiogram. An echocardiogram is an ultrasound or sonogram of the heart that uses sound waves to formulate pictures. And the pictures allow us to see the flow of blood. Is the flow going smoothly through the heart, or is there that stenosis, as Dr. Horne mentioned, or is there also episodes of the flow of blood going backwards, which is that regurgitation? And that echocardiogram gives us a plethora of information, because it allows us to see, in addition to your valve potentially being compromised, is it impacting your heart structurally? Is the heart becoming weakened? Is the heart having to work harder so it's becoming thickened? Or is also the heart becoming enlarged? And we are able to figure out, is the valvular condition mild, or which is something we can often keep an eye on and make sure that we optimize the risk factors that are causing it, or is it getting to a point of severity? And once it gets to a point of severity, that's where we have to talk about the actual treatments for it. I want to first talk about those more mild and even moderate conditions, because I will say that, as we know, commonly, yes, the aging process is the leading risk factor when it comes to valvular disease. Also, more commonly, particularly in communities of color, it's those common risk factors like high blood pressure, diabetes, high cholesterol that may not be as well controlled. So first and foremost, getting patients on medications, addressing lifestyle choices from nutrition and physical activity, that's the first approach to any form of cardiovascular disease. However, if the valve is severely diseased, at that point, we have to talk about the treatment options, and it's either replacing the valve or repairing the valve, depending on the condition. And this is where we as cardiologists work so nicely. We call it the heart team approach, because it includes the general cardiologist, it includes the interventional structural cardiologist, and it includes the cardiothoracic surgeon, who comes together. And I also want to highlight that it should and will include the primary care clinician, and of course the patient as well, who will be part of the shared decision making to determine what is the best treatment option for them. Options that we have right now, I would say in the past, have largely been surgical, where we would either repair or replace the valve. But over the past several decades, we've had the opportunity to see more minimally invasive procedures. If we highlight aortic stenosis as an example, we have a procedure called the transcatheter aortic valve replacement, where we take a valve, a tissue valve, and we're able to actually, through a little prick through your groin, gaining access to your heart and your aorta, and eventually your aortic valve, replace that diseased valve and replace it with that TAVR. That's the transcatheter aortic valve replacement. TAVR, for the most part, when it was first created, was specific for the higher risk patient population. So people who were deemed prohibitive or not probably would be the best suited for surgical procedures, open heart surgery. Now we're doing TAVR on even lower risk patients, but this is again where the conversation with the heart team is really important because we figure out who qualifies, who would be better suited for a minimally invasive procedure like a TAVR, or potentially another option would be surgical aortic valve replacement. Similarly, for the mitral valve, knowing that the mitral regurgitation is the second leading cause of valvular disease in the United States, we have a plethora of options. One includes surgical options, which again can either repair or replace it. But we also have minimally invasive procedures as well that take what's called a mitral clip, where they're able to clip the area that's diseased. And hopefully, if that valve is completely wide open and there's leakiness and regurgitation, that clipping of it will actually prevent that from progressing and actually can help improve it. So whenever you have or have been told that you have valvular disease, you want to make sure you ask the questions. What is the severity? What can I do as a patient from a lifestyle perspective? What should my medication regimen look like? And more importantly, once you get to that severe range, what are the options out there? Are your providers and clinicians discussing it through a heart team approach and including you as the patient in the decision making, because we have a plethora of opportunities and options now that really lead to improved outcomes.
Awesome. Thank you so much, Dr. Bond. I really appreciate you highlighting the heart team approach. I know there are a lot of key players within different care teams, and it's really important for people to understand how they all work together to make sure that the patient is getting the best care possible. So thank you for sharing that. And now let's take some time to hear from our patient advocate, Teresa, who is also our vice chair of Heart Valve Voice US. So Teresa, can you share with the audience your journey with heart valve disease so far?
Yes. Hi. First of all, I'd like to say welcome everyone for hosting this. Thank you, Carissa, and our team at Heart Valve Voice. My name is Teresa Wright-Johnson, and I was born with an aortic valve defect. Cardiology and heart disease looked much different back when I was diagnosed. Again, over 40 or 50 years ago, my parents were told that the trajectory of my life, I wouldn't live until probably 15. And if I exceeded that number, that my life would be very limited. And I know women are not supposed to tell their age, but I will be 52 this year. So that just speaks to the quality of care and medicine and science and why these things are really important for us to have longevity. Throughout my journey, I've had some ups and downs. I've had multiple open heart surgeries and valve replacements. So this cause is near and dear to my heart because I lived it, and also because I see where medicine and technology have gotten us. I like to think of my story as inspirational, but also, as a teaching guide to tell people to listen to their bodies, to be advocates for themselves, and to know that when something feels wrong with your body, 90% of the time, there is something wrong. So one of my passionate platforms is advocating for diversity, equity, and inclusion in this space. And I don't know if you all can take a look at my background, but right now I am in the hospital, and I felt that this was appropriate for me to show this side as well, because we know that when you have certain conditions, you have to exist with them. It's like you coexist with them and you don't know what's going to happen. So that's just a little bit about my journey.
Thank you so much, Teresa. And we really appreciate your resilience and even taking the time to still tune in today for today's webinar, even though you're currently in the hospital. We really appreciate your time in this. So if you're just now tuning in, we just had a great overview on heart valve disease. So as I mentioned, Black patients and other minorities have higher rates of traditional risk factors for heart valve disease are underdiagnosed and undertreated. So Dr. Bond and Dr. Horne, can you share more information about what may contribute to these disparities? And let's start with you, Dr. Bond.
Absolutely. And thank you so much, Teresa, for sharing your journey and also just logging in. I wish you the best in everything that happens during the course of your hospitalization, but you are a true testament to the understanding of the importance of valvular disease and knowing your body, and also more importantly, advocating for yourself. I love the fact you brought up the impact of the need for diversity, equity, and inclusion in this space, because what we do know when it comes to the statistics, communities of color, particularly Black communities, are having staggering rates of cardiovascular disease in general, but particularly valvular disease. They're being diagnosed at earlier and earlier ages, but oftentimes there are delays in those diagnoses. And the reason I think anytime we think about the disparities that we see when it comes to cardiovascular disease, we have to highlight the fact that what actually impacts our health 80% of the time isn't necessarily the biology or the genetics. It's more of the social aspects, those social and political determinants of health. And we know that that includes where people were born, where they grew up, where they were raised, where they have the ability to access healthy nutrition, safe neighborhoods to exercise, and even the ability to access equitable health care. And oftentimes we know that what centralizes the reason that the Black community often has the negative impacts of those social determinants of health is the historical context going as far back as the times of slavery, where enslaved people didn't have opportunities to have access to these things. And the historical context then leads to what we currently see today, which is the still ongoing institutional and systemic racism. So it's important to highlight that these disparities exist because oftentimes we see that all structures, including our healthcare system, have been built off of these old standards, these historical standards that are still trickling into this day and leading to these negative impacts on communities of color.
Definitely. Thank you, Dr. Bond. And Dr. Horne, I would like to hear your insights on this as well.
Yeah, thank you. Sounds very well said by Dr. Bond. And again, I just want to, Teresa, offer my thoughts and prayers, and really just want to speak to your grace and your courage, your perseverance. You are the face of heart valve conditions, which is in fact a chronic condition that we live with, just like we live with any other chronic condition, such as high blood pressure, diabetes. And, I think that it's so powerful because the fact that you are here today at 52 years of age is because of, to your point, the innovation. And that's the part that has been so encouraging, but also frustrating, right? I mentioned earlier that only 3.8% of African Americans in the country get access to transcatheter aortic valve replacement. So why do I say that? It's because we do now, as a medical community, have so many advances in our technology and our treatment options, but we have to at least get that information to the end user first and foremost. I always say that cardiology is the one area in medicine where ignorance isn't bliss. What do I mean by that? Because nobody's proclaiming here to be God or any other power above what it is that we possess, with the benefit of a lot of training and support around us. But if we find out what's going on with the heart, there's a lot of things that we can do and almost nothing that we can't. What do I use as comparison? My mother passed away this past March from Alzheimer's. So as a medical community, we're still not there. I just bring that up as an example, right? So the complexities of the cardiac conditions, but we have so many advancements in our technology, and that's the reason why it becomes so disheartening and so frustrating that these disparities continue to exist, and they exist, okay? The reality is that when Rachel brings up topics such as institutional racism, let me put it in a little bit of a different context. Part of the reason why Black folks in particular, people of color, unrepresented minorities, get underdiagnosed and undertreated, and it is multifactorial, but we do know the facts of which they are. It's not something that's just ephemeral and we don't know how to fix it. We know how to fix it. But if you look back into the manifestations of the clinical symptoms of a heart attack, we asked in Massachusetts, middle-aged white men, what are the symptoms that they get when they're having a heart attack? And it was a squeezing chest sensation, elephant sitting on your chest, radiating to your left arm. But what we've now learned over time is women's manifestations of chest pain are very different, right? Which is why women are treated least aggressively for heart disease. So it's very clear there's a direct one-to-one correlation. If you don't actually ask the questions and understand the patient populations that are suffering from the disease state disproportionately, you're not going to understand how to treat them. Right. So that's the first step. And that's why we talk about the importance of things such as clinical research and research trials and making sure that the people that we're studying are actually the people that are disproportionately affected with disease state. So we actually know that the treatment modalities that we're coming up with are actually going to help treat them. So there are two other points of this pendulum that I want to bring to our attention. There is unquestionably implicit bias. Quinn Capers, who's now head of at Howard University and a pioneer within cardiology within North America for certain, and I'm sure his reach extends beyond its domestic borders. But the reality is, as people, we have biases. So why would one think that providers or healthcare practitioners, extenders, and the like are somehow void of that same bias? The reality is that when people come into the healthcare system, they oftentimes get looked at in one of two different ways, right? Whether it not just be just a pure race cognitive dissonance, but also based on economic status, where you are within this particular strata in the United States, where we look at people. So the reality is that implicit bias exists. We know that for a fact that if you look at in terms of prevalence of aortic stenosis, the question is, oh, well, people will say historically, people aren't saying this as much anymore. People would say that, oh, well, do Black folks just get less aortic stenosis than their white counterparts? But if you look at, as Dr. Bond noted, that if you look at using ultrasound technology, so if you look at long-term care facilities, right? So people that happen to be within a confined area and they're able to be followed longitudinally, and you do echocardiograms, they find that there's equipoise, meaning that Black folks have just as much as the prevalence of aortic stenosis compared to their Caucasian counterparts. But in the real world, what happens is African Americans don't access the healthcare system as much for a multitude of reasons, and we know what they are. As Dr. Bond noted, many of them are social determinants of health. There's no question the trust deficit, as Rachel went back to slavery, but I'm going to just take it even more recently than that, going back to Tuskegee, which really, to be quite frank, ain't that long ago, folks. Okay, we still have people who are living today, our grandparents, our great-grandparents that lived through that. And so there's a lot of work that needs to be done with actually physicians, and I'm one of them, taking the responsibility and the ownership and the onus to do better. Right. But then the patients on the other end of the spectrum, I want you to also advocate for yourself as well. And that's why I'm so glad that you're on this phone call today, because you know your body better than anybody else. And if something ain't right, it's important that you seek care and you ask questions until they're answered to your satisfaction. And if that person with whom you're interacting initially is not making you feel comfortable in that care environment, then you ask for a second opinion. And you have resources. That's why we're here today, to let you know we're a resource. Right? To reach out and say that, I want to find out whether or not I can speak to somebody else to learn more about this particular disease state. So again, I hope that provides some color. And I know that Teresa, Dr. Bond, and I do want to hear from the people on the call. So please don't, again, be shy, and make sure that you put something in the Q&A or raise your hand, and we'll make sure that we have an opportunity to answer your questions directly as well.
Yes, definitely, Dr. Horne. And thank you, Teresa, again, for sharing your insights. So just to pivot from what Dr. Horne mentioned, just about patient advocacy and how people can advocate for themselves with their care team, Teresa, do you have any tips for the audience on just how you can have a conversation with their care team on what you may need, especially as a Black patient?
Absolutely. My advice is always, always be authentic, be honest with what's going on with you. Tell your provider what's going on. Dr. Horne, I want to revisit this because this is so important. The medical mistrust. I, again, am the descendant of someone who was involved in that Tuskegee experiment. So when we think about, medical mistrust, we want to go all the way back to slavery, but we don't have to go back that far. You know, you can talk to someone where something occurred yesterday. You can, you know, look at in my family when we have generations down. What my dad saw with his uncle really carried on. So, you know, I urge anyone when they're seeking care, be honest with your provider. If you feel like you are not being heard, if you feel like you're not being listened to, as Dr. Horne said, go get a second opinion. You deserve to be heard. And as a matter of fact, your life depends on you being heard. And if we can't advocate for ourselves, if we can't speak up for ourselves, if we can't tell what's wrong with us, then how do we expect anyone to treat us? And again, when you feel like you're not being listened to and you're not being heard, the pen is mightier than the sword. Okay, there are checks and balances now that are in hospitals and in institutions. Right, right. That is my advice to anyone when they feel that they're being dismissed. Right, file a complaint. You know, we have to do what we can to break down this systemic bias, and it really does start with us. Right. And I want everybody that's on this call to listen to this part. Eliminating these disparities and these biases, they don't only fall with us as patients. You know, we have to ameliorate the burden from the patients. And you really have to examine who you are, where you are in this healthcare spectrum, in the healthcare ecosystem, and what role do you play. So just to wrap this up, my advice to patients, know your worth, know your voice, know that you have a right to be heard and you have a right to be cared for. Those things are very important. And remember, your life depends on it. And if you speak up or if you don't speak up, then somebody else's life will be affected by that too.
Definitely. Thank you, Teresa. That's really impactful and powerful. We do have a few audience questions I just wanted to take some time to answer. We have one question. Is there a resource to understand echo readings or echocardiogram readings for patients? So Heart Valve Voice actually just launched a new resource in partnership with the American Society of Echocardiography and American Heart Association Target Stenosis campaign to outline for patients how they can decipher the results from their readings, as well as what the importance is for or why you need to have an echocardiogram in the first place. So we'll put the link to that in the chat, and that resource, oh, my colleague went ahead and posted it anyway. Thank you, Rahama. So this is a really impactful resource that we are launching today on Heart Valve Disease Awareness Day. So we hope people take the time to look at it and share it with your partners and colleagues. We also have a question from the audience. It says, I have a friend who was 74 and the other had a stent procedure that was not successful. They said they want to try again. Is it safe or should this be reviewed differently? Dr. Horne or Dr. Baum, I'm not sure if you want to answer this to the best of your abilities.
Dr. Bond?
Our goal with this webinar is to give you just a plethora of information about valvular disease and overall cardiovascular disease. I would encourage that if there's questions coming from your friend, that they actually direct those questions to their healthcare professional. The limitation, of course, is that when we don't know the details, it would be hard for us to weigh in and it wouldn't necessarily be appropriate. But what I will share, as Teresa very nicely stated, is that if there's questions about the trust of the provider that they're working with, or if there's questions about the procedure itself, asking those questions and coming to the appointment with those questions is going to probably be the most impactful thing that you as a patient could do. I always encourage patients, how you advocate for yourself is also being educated as best as you can about your particular condition. So trying to do your own research, but making sure you use trusted sources, as noted from the Heart Valve Voice, or even a lot of our cardiovascular societies have a plethora of information, the Association of Black Cardiologists as well. an organization that both Dr. Horne and I have leadership roles with, and we volunteer our time with. They have lots of valuable information that talk about valvular disease and cardiovascular disease as a whole. So going to your doctor's appointments with questions, that way you can target the direction and what you think the best management looks like for you really does make a significant difference. And what I always tell my patients is we often come prepared when we're speaking with when we're doing our taxes and we're going through our taxes, we come prepared with questions, we come prepared with documents. When we see you in the office, we want the same. And most clinicians actually appreciate that, because then we'll be able to have you leave the appointment feeling that the plan of action is your confident plan and both of you made those decisions together. So I would highly suggest that your friend do that with their healthcare professional that they're working with. And if they still have questions, it does not hurt at all to get a second opinion.
Awesome. Thank you so much, Dr. Bond. And we do have another comment in the chat here. They said that they liked what Dr. Horne said about taking accountability. We are now in a time where Black doctors may not even be trusted, even if they are not given alternative measures other than taking medicine, or that just manages and never really cures. So it's definitely important for even Black practitioners to take accountability, address any biases they may have when treating Black patients in order to move the needle in health equity as well. We do have another question as well. This is more about perhaps some of the symptoms they're having with their PCP and they're getting heart murmurs. They said, I never had any symptoms, but my PCP heard a murmur when I was in my 40s, and I started getting echoes at this time. In my 60s, I need a replacement again, and I never had any symptoms. Everything showed up on my echo. I had a great team taking care of me, and some people should realize that they may not have symptoms and what they should do about that. So yes, definitely. Definitely understand that taking the time to answer any or get the treatment that you needed, even if you do not have symptoms.
And I think that's an important probably comment to just pause on, because as noted, murmurs don't imply symptoms. That's oftentimes the first sign that there is something going on with the heart valve. As a result, I think that it sounds appropriate how the care of action is that a murmur was heard, echocardiograms, which is again that ultrasound of the heart, was periodically performed, and then eventually several decades later, the valve needed to be replaced, but they found it early and there was a success to that. So I think it's important that for those out there who have been told that they have an extra heart sound or murmur, that they're asking the questions, should we do the next step, which is get that echocardiogram, get that ultrasound of the heart, potentially see a cardiologist as well, so they can best prepare for their future course of action.
Definitely. Thank you. And that's a really important thing to know. We do have one last comment or question. Oh, Dr. Horne.
Chris, because it's a really important point that I also want to add. And that comment was very helpful in terms of that individual being identified with a murmur earlier in life. And there are certain variations of aortic valve disease in particular, whether it be unicuspid, which is very uncommon, but bicuspid versus tricuspid aortic valve disease. But I do want to make a comment about symptoms, okay? You'll remember at the beginning of this conversation, I noted that between 26 and 29% of people older than 65 years of age have aortic stenosis, and I mentioned that 1 out of every 8 adults 75 years of age and older have moderate to severe aortic stenosis, and that the fastest growing population in the United States are people 85 years of age and older. Why do I make that point? Because, especially within the Black community, so my grandfather was an AME minister, and there's a common, it was commonly said that if you live 70 years of age, then God has granted you with a long life. And anything that happens with me slowing down with my activity, that, that's me being grateful, as we all should be, having the grace to have lived a long life, and I'm just slowing down because I'm getting older. So I would like to make the distinction that we are living longer, okay? Right. And it's important that while I am not trying to dissuade anyone from their, religious beliefs, I have my own, and that's not a part of this conversation. But my point is that there could still be things happening physiologically that might be able to be addressed, that might be enabling you to live with a particular purpose and quality of life that are beyond just your stated age. And as it pertains to symptoms, a lot of times when we are older and no longer as active as we used to be, we don't have necessarily a great understanding of the degree to which we do or do not have symptoms, right? Because I asked, well, what's your typical day like? I'm like, well, baby, I get up, make breakfast, I, move around the house and do what I need to do. But I'm like, when's the last time you had to, what happened if you had to move a little bit quicker to run after your grandbaby? Well, they said, well, somebody else better grab them, right? So my point is sometimes we don't actually push ourselves to know whether or not we're truly symptomatic, right?
Right.
So you might have some manifestations of that particular disease state that might not be actually presenting themselves to you because you're not pushing yourself as much as you have had to in the past, right? And again, as I made that point in terms of there being a 50% risk of mortality 2 years untreated, it is important that we don't just dismiss, say, well, I'm slowing down a little bit, but I'm okay. Because once that disease state hits you, it can be very dramatic, right? And so I just wanted to make sure that I made that point that, symptoms might be different than you might appreciate as we get older and sometimes just, are become a little bit dismissive or try to, say that it's something else other than what could be the valvular pathology.
Thank
Yeah,
you. That's
I was gonna just add, my colleagues that I work with in the structural field, they say it very nicely often. It's like looking at yourself in the mirror every day. When you look at yourself in the mirror every day, you don't realize how much you're aging. But then when you look back at your yearbook, you're like, oh my goodness, I look like a different person, right? So if you look at your high school yearbook. So as Dr. Horne is alluding to, you may not think you're having symptoms, but there probably is a slow progressive process going on. So just be attuned to that it may not be just the aging process. It could be the actual valve itself, because that's sort of the natural history of these valvular conditions is as you get older, oftentimes the valve itself becomes more diseased.
definitely. Thank you. And also this next question also hits on another point that we wanted to address during the webinar. Are there any policies the the Association of Black Cardiologists are advocating for to eradicate racism or discrimination in the medical field, especially as it pertains to heart valve disease?
Yeah, absolutely. The Association of Black Cardiologists, which for those on the call, if you're not aware, it's a nonprofit organization created back in the 70s. The sole purpose of the organization that was created by Black physicians was to ensure that we were focusing in on the highest risk patient populations and the Black and Brown and other communities of color being that. One thing that the Association of Black Cardiologists, or the ABC, highlights is that they're in support, like other cardiovascular societies, in making sure that we revamp medical school as well as nursing school training, getting education even in the first year on courses that include social justice, race and racism, and doing trainings particularly to that is something that we are encouraging. We also want to make sure that education on national, local, and institutional histories related to race and racism is also implemented in the curriculum, because that's not standard practice, right? Dr. Horne talked about the Tuskegee experiment. That's often not taught in medical school and nursing school. And we, at this moment in time, especially associations like the Association of Black Cardiologists, are supportive of that and trying our best to help to revamp that education. And I would also like to add that I think it's important that healthcare entities do conduct at least annual reviews of both conscious as well as unconscious bias, because that's the only way we're going to actually see probably the ability to move the needle in the proper direction. And organizations like the ABC are helping to support that. And they're more importantly advocating also at the national level, making sure that Congress is aware of the importance of including social determinants of health and the support and funding of social determinants of health in healthcare.
Definitely.
Can I add one comment? Carissa, can I jump in on that as well?
Yeah, definitely.
Yes, I just want to embolden that what what was just said. When we have a courage to care, right? And I think that's what the bottom line comes down to. You have to have courage to care, to really fight these implicit biases. And my thing is this, we can no longer accept or be content with people just saying that they don't know about what happened, that they don't know, oh, well, I didn't know about the Tuskegee experiment. I didn't know about this. You know, when we are providers and we get into this field, it behooves us to know the communities that we treat. It behooves us to know the history of the people. It behooves us to know their individual situations. Individualized care means greater patient experiences. It means, you know, probably more longevity. It means a greater quality of care. And again, that can't just be on the person living with illness. That has to be something that everybody that's involved in this healthcare ecosystem, you know, you really, really have to know, and you have to understand that that work lies with you. So I just wanted to embolden that comment. And I just wanted to say, you know, when you talk about medical schools, you know, we need to have people who are living with illnesses come to these medical schools and teach. You know, I can't tell you how many institutions that I've gone to and spoke with um, doctors and people in school and, you know, even nursing and care staff. And you realize that that's an unmet need. You know, the only way you change action, the only way you bring about action is to change systems of thought. And it begins with yourself first, of course, but it also begins at the level of institutions. We have to get people before they graduate, before they start interacting with patients. Because if you are not privy to the information, or, you know, you, like we just said, have these implicit biases, then of course they are going to come out probably in that first visit when you're speaking with someone.
Definitely.
Carissa, I have one other just deliverable. I think it's important that in terms of the policy question, and thank you again, Teresa, for those comments. Very powerful. So I'm very proud of the work the Association of Black Cardiologists has and continues to do. As Dr. Bond mentioned too, this is a volunteer organization. This is something that we do because it's something that is consistent with our values and belief systems, but we don't just talk the talk, we walk the walk. Somebody mentioned earlier in terms of who are the trusted providers in this space. This is the work that we've done for 50 years, right? We just celebrated our 50th year anniversary. And so specifically, I would like for us to provide in the link, and it can be happen through, again, the link that was just provided by my colleague, Dr. Bond, our website. So we just conducted our second roundtable from the Structural Heart Committee, of which I'm you know, was one of the initial co-chairs when we actually started the committee in 2015 after the transcatheter valve therapeutic came out, showing only 3.8% of Black folks got TAVR over a 5-year period of time. And so we just came out with a clear policy statement, a draft. It's a document here that's about 36 pages, and it goes specifically to the policy recommendations that we make for our insurers, the payers, where we look at the people that are influencing policy, looking at you know, the NIH. We're looking at NHLBI, people that are actually influencing the funding streams. So that would be the Center for Medicare and Medicaid Services, which is under the auspices of the Senate Finance Committee. We also talk about the role that industry should play. We talk about the role that our civic partners, our clergy, our patients. So this is a very robust and comprehensive document that, again, I was actually one of the obviously co-moderators of that particular roundtable. Very proud of the work that we have and continue to do. So I'm proud that our other societies have taken more of an interest in addressing health equity within valvular heart disease in particular, but this is something that we have been at since its inception within the Black Cardiology leader of this. And I would encourage everybody to read this and continue to engage with the Association of Black Cardiologists to continue to be there to try to meet those who are most vulnerable and a part of our patient population, a part of our family.
Thank you, definitely. And we also shared the link to that in the chat as well. And we do have a few questions in the chat, sort of to piggyback on our conversation about what physicians and hospitals can do to move toward health equity. So we do have a question that says, what guidance do you give physicians in and out of your referral network to ensure patients of color move towards being treated or monitored after being diagnosed with aortic stenosis to avoid falling through the cracks and being forgotten about? And Dr. Bond or Dr. Horne, feel free to piggyback on that question.
Go ahead, Dr. Bond, please.
Yeah, no, absolutely. I think the premise of what we realize is that we are always learning. Even though many of us are practicing for several years, we still are forever learners. And as a result of that, providing education about these disparities to our colleagues is, I think, one step for them to really hone in on their unconscious bias. Everyone has these unconscious biases. It's just a matter of you realizing it and becoming comfortable and acknowledging it. The other thing that I think has been really pivotal for me, at least locally in my institution, is that I've provided a lot of education to our primary care clinicians. The primary care team is always the gatekeeper, usually to the cardiologist, and oftentimes they're the first ones that are diagnosing a concern for valvular disease in particular. They're the ones that should be preferably hearing that murmur and thinking about getting you to the cardiologist. So as a result of that, I have provided a multitude of education around valvular disease, making sure that they are aware about the fact that there are disparities that exist when it comes to valvular disease, but cardiovascular disease as a whole. I do think people on the call should understand that this is not just specific to valvular disease where we're seeing these disparities. It's across all forms of cardiovascular disease, heart attacks, congestive heart failure, and other measures. And many of these things are preventable. And I think that the more we talk about it, the more people understand that biases exist, and we're sort of working to understand our own individual biases and work towards removing them, the better off it will be. I do want to also highlight that one way that we've been effective is to include community leaders as well. There was a question prior to that original question about how we can engage the Black community. And I think that the Association of Black Cardiologists does a phenomenal job in highlighting that. They actually just had a paper published in the Journal of the American College of Cardiology circulation expressing the importance of a trusted community leader who should be part of the care team. Right. So when we talk about the heart team, even extending it to that trusted community leader, because there's such mistrust in these patient populations appropriately, by having that person who could be the bridge between us as the clinician, the healthcare institution, and the community as a whole, it can make a significant difference. And the ABC does a phenomenal job because they actually go into the communities, they do training where they actually train those in the community who become community health advocates. And these advocates talk about valvular disease. They talk about the signs and symptoms to look out for. They talk about the importance of knowing what a murmur is and really hone in on those questions that you should be asking your healthcare clinician. And I think more targeted approaches like that, where we include these community health advocates, and more importantly, those that are trusted in our community, are actually going to make a significant difference.
And I just wanted to highlight a comment from the chat. That one of our audience members said that their daughter is currently a third-year resident and she faces the same issues many Black patients face. And she just wanted to thank you all for sharing this important message. So thank you for joining. And this is a really timely message, especially for today. And I just wanted to pivot back to Teresa just to get her perspective a bit on just how patients can continue to advocate for themselves in terms of health equity, especially through the journey of diagnosis and treatment of valve disease. Just how can they find information about valve disease where they can turn to if they're unaware of some of the things that they may be facing moving forward, or where they can go to just to find a trusted resource?
Right. So, again, like it was just so eloquently stated, there are so many community resources, and I can talk about our organization with the Heart Valve Voice. You know, we have Ask for Echo campaigns. We have different programs that's being developed. But I guess my main point of reference and my advice would be find your trusted community sources, be it an advocate, be it church, the Divine Nine now, we have Black sororities and fraternities that are really out here. You have to find someone that's doing the work on the ground. That's a very, very important point of reference. And again, we have to build our community teams. We have to build our resources. And your team is like not only your medical team, but it's your community advocates. It's the people who you go to, not only for medical advice and support, but also for psychological and emotional support. That is often a side of a diagnosis that really gets left behind, that I think we at Heart Valve Voice, we do a really good job of reaching out to those communities for support. That's a big factor. And just never forget, while you're maintaining your physical health, never forget to maintain your emotional and mental health. Because with the diagnosis comes a lot. And it's often times a lot for us to carry. So, just lean on your community and your community support. And again, remember, you are your best advocate. You listen to your body first, and then you demand to be heard.
Thank you. That's very insightful and impactful. And I hope our audience took away a lot of information from those comments, as well as from Dr. Bond and Dr. Horne. So now that we only have a few minutes left of our presentation, I just wanted to take the time to thank you all again for joining, and a special thank you to our panelists for taking the time out of their day to speak on this important topic. So I just wanted to close out with asking our panelists, what are some 2 things to know, as well as 2 things to do you would like to share with our audience? And I'll start with you, Dr. Horne.
Thank you for having me. It's been quite a pleasure, a delight. The 2 things to know would be that, again, we are living longer, and it's important that we make sure that we're familiar with the disease states of which we are going to be prone to potentially becoming susceptible as we get older, right? As we get, women know that breast cancer is something that they should be screened at certain stages in their lives. Men know that prostate cancer is something too, but all people as we get older should make sure that they're aware of valvular heart disease. So I think that you should also be encouraged to know that there are technological advances that are available to you. And you should also be encouraged to know that you have a community of people within organizations such as Heart Valve Voice and Association of Black Cardiologists that are resources, and don't be afraid to use those resources. So it's been a pleasure, and wish all of you guys all the best moving forward. And thanks again for including me in this programming.
Thank you so much, Dr. Horne. Let's turn to you, Dr. Bond.
Definitely. So I want people out there to realize that although the population is aging, valvular disease is on the rise, it is a largely typically preventable condition, and it starts with the basics of knowing what your risk factors are. Yes, there are forms of valvular disease that are congenital, that are oftentimes hard to prevent because you're born with it. But the more acquired forms are the ones that often, when we control our basic things like our blood pressure, our
Mhm.
cholesterol, our blood sugar, making sure that we're eating healthy and we're being as physically active as we can, it could actually either prevent it or at least delay the onset of it. So finding the next step would be finding that trusted healthcare professional, that healthcare clinician that you could work with to make sure that you're able to optimize your health and make sure that all of those risk factors are ideal. I would say would be the most important aspect of how to make yourself live the healthy life that you want to, with the importance of quality, focusing more on the quality of your life, probably more so than even the quantity. So I would say, leaving you all today, make sure that you do have trusted members of your healthcare team that you can speak with, you feel comfortable asking questions about. And more importantly, if you don't, getting that second opinion and really searching for that team until you find it, and going to organizations like the Heart Valve Voice or the Association of Black Cardiologists, where oftentimes we have a list of healthcare physicians and clinicians that are members of these organizations, will ultimately make a difference as well.
Thank you. Awesome. And last but not least, let's hear from you, Teresa.
Yes, the important thing to know is that your life matters. I don't care who you are. I don't care your socioeconomic status. I don't care your gender, your race. Your life matters. So that's number one. And once you operate from that principle, you understand that because your life matters, you have an active role in your health care. And when you have an active role in your health care, you will remember that your providers are not working for you, they're working with you. So that's my first point. And then my second thing that I want everyone to know is that hope matters. I am proof of what hope and faith and medicine and technology can do. So just keep fighting and never, ever lose hope, because you never know what lies ahead. Sorry. You never know what lies ahead.
Awesome message. And thank you so much, Teresa. And once again, thank you all for joining us today. So we would like to close out our webinar. And if you have any questions or want more information, feel free to email us at info@heartvalvevoice-us.org. And we hope to see you again on the next webinar. Thank you again. Bye-bye.
Thank you. Bye.
Thank you. Bye.